with patients. It would be a broken nose in a bloke, and it would be anemia in a girl. And if it's not anemia in a girl, it's something called Polycystic Ovarian syndrome, because it plays with your hormones. And then they give you more hormones so you can fall pregnant. Makes sense? My position on that is it's quite interesting, but you'll find that a lot of the patients, which I'll touch on shortly, particularly the women who do have a history of infertility and difficulty falling pregnant, are also patients with a history of tonsillectomy in the first 5 years of life. So I suspect here that the body's saying, mate, I can give you enough oxygen for one, but I'm buggered, I can't do it for two. Sorry, you're not going to have a kid. What I call my adaptive thresholds. A lot of the things I see in my game is probably not a lot different to fire. So, you know, for fire I need heat, fuel and oxygen. Take one of those things away and I don't have fire. And similarly, when we look at medical comorbidities, you know, if we can manage maybe one factor out of three, that would throw the patient under the threshold, and then maybe we don't get expression of medical comorbidities. And Romola, that's what I was sort of touching on a little bit earlier when we were talking. So even if we could just reduce the severity or the frequency of presenting signs and symptoms and slowing disease progression, you've only got to take one thing out of the fire. That might be anemia in a female. They're going to think you're pretty special. If they then come back and say, you know what, that's amazing, I was anemic. And you know what, doctor, I've been bleeding from my bowel for 3 months and I haven't told my doctor. So a real common one with bruxism and TMD. Another reason why I ask you, have had a blood test within 12 months? I do a lot of TMD patients, and the first thing I'll do is say, have you had a blood test within 12 months? And if you haven't, the first thing I'm doing is you're off for a blood test. The number of patients that I've picked up with gastrointestinal cancer with TMD is quite alarming. And you stop the bleeding and their TMD stops. So when we start to look at dentofacial things, what are we going to see clinically? Well, a lot of these things you'll be aware of, but we're going to basically see the growth rotation. Okay, the tongue's down, we're breathing through the mouth, so we get a dorsal pattern of growth rotation in formative years. Right? So let's say up to 16 in a male, and let's say up to 13 or 12 in a female. They're going to get high angle, they might get softening of the lower jaw, but part of that might be also because we're mid-face deficient. We're going to end up with cross bites, with the top teeth. You know, the tongue drops back and the lips and the cheeks take over. That's a very good analogy. I like that analogy. The tongue drops back and the lips and the cheeks take over. And you'll see this. I'll show you some slides. So then we end up with the maxillary constriction, the high palatal vaults, and we start to get the cross bites. Now, the other thing that you'll see too is you'll get what we call scissor bites, where the top teeth are on the outside of the bottom. You think, man, how's that possible? Well, Dr. McIntosh threw a bit of light on this, and it's to do with the positioning of the tonsil within the pillar. And basically, if your tonsils are up high, what they call A-grade tonsils, we're more prone to get dorsal rotation of the mandible. Whereas if the tonsils are down low, the tongue gets pushed forward. Gets pushed forward away from the tonsils, and it spreads out and it pushes the top teeth out, and we end up with a scissor bite. And often they're the class 3s. All right? Impacted teeth. Be mindful of palate displaced canines. If you see a palate displaced canine or an ectopic upper 6, that's a red flag. Nasal crease I'll talk about, enamel spotting I'll talk about. Don't get bogged down on retention cysts. Retention cysts are something I'll show you in a minute, but they're innocuous. There's not really direct cause and effect, and I'd leave it at that for the time being. Understand that if we're grinding a lot, not only get dental problems, we're going to get jaw joint problems. They're just at the other end of the stick. And I believe a lot of internal derangements, the stage is set in formative years with mouth breathing. So the jaw drops downwards and backwards. We look at the craniofacial expression, but we don't look at what's happening in the joint. And a lot of these patients, the disc develops anteriorly. So now I've got an anteriorly displaced disc at a very early age. Then I couple that with sex hormones and the pubertal growth spurt. Muscle mass goes through the roof. We start to brux a lot, and we start to load a joint that's dicky, and then we wonder why we get joint problems. Dental complications, I've touched on a lot of that, but just bear in mind that a lot of the orthodontic problems we see, 50% is genetic and 50% is mouth breathing, without question. And these people then have their orthodontic treatment, and then they wonder why we're getting relapse in our 20s and our 30s. Unfortunately, the orthodontists don't often see the relapse. We see the relapse, but the orthodontists don't. They're out of their hair after 12 months. They want to get rid of them. Dental phobics, the people who hate coming, they only hate coming because their body knows that they need this for food, water and oxygen. And you are an imposter if you're in there. So, you know, the dental phobics, we think, oh man, I can't handle this. She can't even tolerate nitrous. Well, chances are nitrous oxide, they can't even breathe it anyway. Chances are, forget about the nitrous oxide, just give them 100% oxygen. They're quite happy with that. And the other simple things is the red flags is inability to tolerate oral appliances. He's gone to sleep. I'll take photos of him. But inability to tolerate oral appliances. I made this patient a splint and they just can't wear it. I just spit it out. Or, you know, I wear that splint and it's killing me. My teeth are killing me. Well, that's telling you that thing is not meant to be in there. That's a red flag. Stop dentistry, go medical assessment. The patient's telling you something here. And if they fall asleep like this bloke does in dental procedures, that's another red flag. Oh no, I don't have sleep apnea. So again, these are the things that we see. And these are just some models. But this just demonstrates it quite nicely. So you learn to look at the shapes of their arches. And that demonstrates it quite well. Where you get the parabolic form with the tongue, because it's down there, right, letting air in. And the poor old top jaw really cops it. The buccinator goes through and it squishes the top jaw in. The enamel spotting, we get that because the enamel gets dry. And we get the nasal crease. We look for the nasal crease on kids. That's from doing this. All right? Look for the nasal crease. Retention cysts, don't get bogged down with them. Just because I've got a retention cyst doesn't mean I'm an airway patient. Look for your palatally displaced canine. So this was a kid that was referred to me. He was 9 years of age and he's referred by the school dental service, and the concern was that he had ectopic 1, 3 and 2, 3, the upper canines. And they're going nowhere and we've got to treat this kid. So the simple thing is I palpated and I could feel the 3s. I'm not worried about them. What I'm more worried about here is maybe why this kid has palatally displaced canines. And then my attention is then drawn and I look at the septum upstairs here. That's the little button. Up here. Look up here. That's where I draw my attention. And so what I elected to do with this kid was not much. I monitor him. He was 9 years of age. He didn't have any medical problems, had a history of allergies. And I waited until he was 13. I waited till the 7s came through and I reassessed his occlusion. The interesting thing to pick up with this is when orthodontists take their photos, they will take their lateral photo, they'll take their frontal photo, but the more important photo is the one where I can look for the kyphosis. That's an air sniffer. All right, so you look at their posture, you look at the way they walk, but they're trying to get air in. It started at a very, very young age for this kid. You look at their nostrils, look for different shape. This kid was half asleep, right? When I measured him up, we can see the dorsal growth rotation, where the jaw grows downwards and backwards. And the main thing that came out with this kid, he was a bit small in the bottom jaw, he was a little bit hyperdivergent, and he also had a little bit of internal derangement, but nothing nasty. And dentally, okay, his eye teeth are sticking out a little bit, he's got a reasonable occlusion, and so what will be the treatment? I do a bit of ortho, so we'll just return the maxilla back, we'll expand him and just finish him off. But then comes the retention. How are we going to keep the result? He's got to wear retainers forever and a day, so I would use a fixed retainer in that case. Here's another bloke here, and he comes in and he was pretty pissed off because he'd been to a dentist, and this dentist just gave him a real serving about not cleaning his teeth properly. And he said, mate, I brush my teeth twice a day. Okay, I don't floss, but I go to church on a Sunday. And I say, well, mate, this isn't to do with poor diet and poor oral hygiene. Just have one look at his nose. It's like someone smeared it across his face. Right? He's had it broken 3 times by the same wife. No, I'm only joking. But what I'm getting at is when they can't breathe through their nose, they have to breathe through their mouth. And now they get junk on their teeth. These people are brushing probably as best as you and I are, but they can't maintain it for the simple reason that they can't breathe as well through their nose. So don't pick on them. If you pick on them, they're gone. But if you offer them, hey, maybe it's because of this they like you, because that makes sense. And lo and behold, let's look at this poor bloke. Well, he's got all the signs of localised advanced breakdown. So he's an unstable bruxer, localised patterns of deterioration. So where I come from, I'm a little bit old school, but you know what, it still works for me. But you know what, if I couple, I don't care what any periodontist says, if I couple an active intrabony lesion or a plaque-induced active intrabony lesion with occlusal trauma, you know, I'm going to get these sorts of things here without any problem. And it's just the same teeth left and right. You know, so he had the 6 that was badly broken, and he had the 5 upstairs on the left that was badly broken, and he had the periodontal problem, endo-perio problem. The same teeth left and right, nothing new. But there's your pattern. But before we dive in and do dentistry, A, he's going to be difficult to treat. B, he's not going to like coming. And C, maybe we should start to consider medical assessment parallel to, if not before, doing too much dentistry. So when we start to look at medical comorbidities with these patients, we break it down into kids and then adults, and whatever applies to kids will also apply to adults. But I think the key thing, and this isn't like all-encompassing here, there might be a few things I've left out, so excuse me if I have, but with kids, bedwetting, red flag, right? Cor pulmonale. What's cor pulmonale, Dr. Nolder? You should know. So that's right-sided congestive heart failure due to problems in our pulmonary vasculature. So this is, again, leading with the breathing. Night sweats, you know, kicking off bed sheets in the middle of winter. Why would we kick off bed sheets in the middle of winter? Well, in the middle of winter it's cold and I'm blocked up. And when I'm blocked up, I've got to breathe through my mouth. And when I breathe through my mouth, that's fine until I get into deep sleep. And then the tongue drops back, the resistance in the airway climbs, and the heart's screaming out for oxygen. So the brain says, don't worry, heart, let's just work harder. And we're going to work real hard. And so we're going to increase the core body temperature. That little motor is going 100 miles an hour. Right? So this is what we see. Kids are a little bit different. And again, the hypnocapnia and the migraine, this is where we can't connect the bruxism. A lot of it is to do with oxygen saturation as well as carbon dioxide saturation. The two are brothers and sisters. You can't look at them independently. Gastrointestinal, obviously the dry mouth. Reflux. When we mouth breathe, we generate negative pressures within the esophagus.